Friends, this is Patella dislocation recurrent in 20-year-old female. The translation of lateral to the lateral is more than 2 quadrants, and also medially it is able to be translated. That means lateral structures are not tight. Tibial tuberosity is slightly lateral, where TTTG distance is 1.5, and trochlear dysplasia is milder form. So, and flexion of more than 45-degree patella is seated properly, it is not able to be translated medially or laterally. That means to up to 30-40 degrees of flexion only, this patella is getting dislocated. We are planning to do MPFL reconstruction. These are the layers. We have made 2 tunnels horizontally through and over drilling with the 4.5 mm drill bit. These tunnels are in the starting. First will be about 4 mm down, distal to the proximal pole, and second is about 1 centimeter in the gap. We are fixing the swivel lock anchors, and the graft is being passed to about 5 mm to 1 centimeters. We have made a loop of graft. Both the ends are now being passed inside. This is a semitendinosus we have harvested, and then and once we have fixed it, most importantly, the graft has to be going inside, not just the anchor suture, anchor screw. Once we are confirmed that the graft is very snugly seated in the medial part, then we will check it, pull and check it, that whether it is in a position to hold it. Then we flex the femur. We have to overlap medial and lateral condyles so that there is no double images. Then we will mark the shortle's point in flexion, and once we are confirmed the most ideal point for the femoral fixation, we should not be more anterior, should not be more proximal also. And once we are confirmed that, we are now drilling here with a 6 mm drill bit. Our semitendinosus with 2 loops together is coming to 5 mm, and we are making the 6 mm tunnel here. It is better to drill through and through femoral cortex and put the nitinol wire just next to the bead pin, so that we will not miss the point, the tunnel for the screw fixation. Once we are confirmed the position, then we will make the between second and third layer of the medial synovium, just extra synovial, intra retinacular area. We have to pass these grafts, and then with the loop which will be passed from the bead pin, and now we are going to pull this the threads of the graft through the bead pin hole, and then graft will be now passed in the femoral tunnel. As I was telling, we have to keep the nitinol wire again. We should not miss it, so that we will be not missing the track for the screw fixation. We are now pulling the graft in. Once the graft is in to the tunnel, if it is little tight, we have to hold the artery forceps and slowly loop going on to pull the graft, how we pull ACL in the femoral tunnel. Slowly wind it, turn it, and then graft will go inside. And you can see now we are very nicely in the extra synovium area. We should not damage that, and this is giving the stability to the medial side. And then at 60 to 70 degrees of flexion, we are fixing this, and the colleague is pulling the thread of the graft. Now we are sure that we have fixed it in proper position. Thank you for watching.